Doctors, we are live now.
Good evening, ladies and gentlemen. Welcome to our W3 webinars, which are meant for clinical discussion, and the what, when, and why of every topic is discussed in detail. These webinars are multidisciplinary, and we host them approximately twice a month with multidisciplinary team, and it's something which we all enjoy, and we get very great feedbacks. So coming up with another webinar, we are discussing today, does menopause increase bone loss in PCOS women too? The question here is because when we deal with menopausal women, when we have women who have no protection from their estrogen, which has been there for them right from the time they have been menstruating, once they reach menopause and the estrogen levels drop, the issues related to estrogen deficiency, the most common being osteoporosis, sets in. And this is something which we have all understood, and we have all learned how to deal best with them. But coming to PCOS women, we know that they are hyperandrogenic, and we know that they have higher androgens as compared to estrogens. And in short, we reach a situation as to, do androgens really protect the bone? Do androgens give the same protection as women with estrogen have? And this is a controversial topic, and there's some recent evidence on it. And we're going to discuss this with very, very elegant speakers from different disciplines of medicine. So I'd like to introduce to you, can I have the slides, please? I'd like to first, can I have the speaker slide, please? The first of the experts we have is the director of the Department of OBGYN, Dr. Jyothi Unni, who's from Pune, and she's from the Jankharia Hospital Department. She's been the president of the Indian Menopause Society and was the international representative to the International Menopause Society. She's also the representative of Indian Menopause Society to the Asia Pacific Menopause Federation. And she was the chair of the West Zone Representative Committee of All India Committee of FRCOG between 2010 and 2015. Jyothi is a wonderful person, comes from the army background, and everyone at the Indian Menopause Society is very, very scared of Jyothi's discipline. So when Jyothi is around, everyone behaves themselves because she keeps them absolutely on time. So I'll introduce, so welcome Jyothi, thank you for joining us. We have Dr. Bhavin Jankharia, who's a radiologist, and he has been well known all over India for his work in radiology. His main subspecialty interests are chest, bone, and cardiac radiology intervention, CT, and the business of radiology and healthcare. He's very much into academics, written many books and articles, and also has been the editor-in-chief of the Indian Journal of Radiology and Imaging, past president of the Indian Radiology and Imaging Association 2014. He's had his fellowships in the University of California, and he's been also had been trained through the Royal Brompton Heart and Lung Institute in London. On the personal level, Bhavin is a good friend, and you must be reading his columns in the Midday or one of the newspapers. Very well-read column, and a wonderful person to know. And thank you very much for joining us, Bhavin. Welcome to this seminar. Following this, we have Dr. Abhay Nene, who's a spine surgeon, and he is in the VR spine group, consisting of very well-known orthopedic surgeons focusing on the spine. And his areas of interest are pediatric spinal deformity, spinal tumor reconstruction, tuberculosis, and the osteoporotic spine. And he's been author to over 24 international publications and textbook chapters, actively involved in research and runs fellowships to train young spine surgeons, and awarded the Educator of the Year title by the AOS Spine in 2018. On the personal front, again, Abhay is a is a wonderful person, a great doctor, and he's been a solid athlete, climbed mountains, goes cycling all the way to Delhi, and he does all kinds of, and of course, plays some music, he sings, he does everything possible on the earth. So very, very multitasking person, and welcome Abhay to this program. Following this, we have with us Dr. Shashank Joshi, who has, of course, everyone knows Shashank, and he's been the vice president of the PCOS Society of India. He's been the dean of Indian College of Physicians, past president of Endocrine Society of India, and chair of IDF Southeast Asia. And he's been the Padma Shri Awardee 2015 and International Clinician of the Year 2012. His current research is diabetes, obesity, PCOS, everything endocrinology. Now his focus is COVID-19, and he's written more than 800 papers, published them, and 100 books. Shashank is, again, we just got to know whilst talking before the session that he's been at the cyclist competitive level at the national level. And he's also been an athlete, and that's how he keeps himself so trim. And of course, always obliging. We unfortunately had a last minute dropout, endocrinologist, and I just called Shashank and he has happily stepped in. Thank you very much, Shashank, for helping out at this last minute. Then we have Dr. Tvisha Parekh, who's a consultant sports physician at the Sir H.N. Reliance Foundation Hospital and holds a master's degree in exercise and sports medicine from the University of Glasgow in UK and PhD in sports medicine. She's also an Ayush certified yoga trainer and received additional sports medicine training at various world centers. She has authored many publications, received various awards for the same, and she was a sports medicine doctor at Ladakh for La Ultra for a 555 kilometers run over 5 days. So Tvisha is also a very well qualified fitness consultant and well known for her work in the field. And so we welcome you, Tvisha, for joining us and sharing with us your thoughts. So we go to the actual session now, and we discuss about how we can sort of discuss this issue. So question is that since Dr. Shashank will be leaving us by 7:30 because of another commitment, and since we have requested him to join in, I would like to try and request Shashank to cover up all the common endocrine queries we have. So before I even jump into what is osteoporosis, etc., endocrine point of view, Shashank, I would want your definition of osteoporosis and sarcopenia. So that is something can set the ball rolling, and then we can take it further. Go ahead, Shashank.
So thank you, Duru madam. And osteoporosis, unfortunately, predominantly is defined through a radiological tool, which Bhavin will highlight predominantly on BMT, and it's fundamentally linked to the T-score of -2.5 and below. Then osteopenia is -1 to 2.5, and that's predominantly defined for postmenopausal women. And if it's above -1, then it's normal. So it's basically a BMD-based definition with the way WHO put it. Of course, we have now Abhay, and I'm sure Bhavin will highlight the FRAC scores, the clinical fragility fractures. So they also come into the definition. But currently, the definition is predominantly BMD-centric. And the bone mineral density overwhelms everything else. And therefore, that's the way it's defined. And that's the way we define bone health currently, and will remain for times to come, because when the definition came into existence, there were not sufficient ways to handle the definition with the DEXA-bone mineral density. But now we have that. But currently, what most people follow is an integration of a FRAC score, which is country-specific and geography-specific, with, of course, the BMT scores. And that's where it is. When it is secondary osteoporosis, we don't look only at the T-score. Sometimes we have to look at the Z-score or the Z-score. And there also it's -2 or 2.5 are the crucial cut points. So that's where osteoporosis is defined or bone health is defined.
Yeah. So do we have any Indian standards or put up, as to what we really find in India? Because every ethnicity would have different kind of patterns. Or do we just follow the universal pattern which is there for everyone, or the definition?
For the definition purposes, BMD is standardized.
Correct.
And there is nothing ethnic specific. The bone markers also have got integrated in the definition. But what is different is the FRAX and the fracture risk. So whenever we look at bone health, ma'am, we look at three things. We look at the BMD, which is the gold standard. Occasionally in research, we see bone markers, which are blood markers like osteocalcin and the various other modulators of bone, which are not very robust and reproducible. And third, of course, is the fracture risk. And then we try to integrate all these three in the overall bone health equation.
So what about muscle health?
So see, the point is that the BMD, when you do a DEXA bone scan, we also get a little insight into the muscle, composition, or we are able to define sarcopenia. It does have an impact. Fat mass and muscle mass both have an impact on bone health. In fact, we know that obese people are more protected. People in excess tend to have a better protection or have a better protection on their bone health. So we know that once there is no androgen on board, no estrogen on board, the bone health is less, and it's more fragile and more weak. So that's something which we recognize better now, and that's something which we know better. So that's something which we need to be mindful of when we are looking at all these issues. For example, when you talk of PCOS, the whole environment has to be contextualized in premenopausal states, postmenopausal states, and it has to be BMI centric. It has to factor in the muscle and the fat equation in the picture, because a lot of outcomes related to bone health and bone mineral density are linked to that.
Yeah. So we know that PCOS women are mainly hyperandrogenic, and of course there's a confusion between whether hyperandrogenemia leads to hyperinsulinemia, or whether hyperinsulinemia leads to hyperandrogenemia. They tend to go hand in hand in PCOS patients. So both of them, both insulin resistance and hyperandrogenemia, are known to affect, bone health through the androgens, and the androgens which are in abundance in these women can cause problems with bone health. So question is, do these androgens really help the bone, or they don't help the bone?
So, this has been looked at in a very crucial way, because we today look at evidence-based medicine. And in the evidence-based medicine, overall, there is a negative impact of polycystic ovarian syndrome on bone health. Julia Pivozin from Brazil in 2019 published a beautiful meta-analysis. And she and her group looked at every study published on planet Earth from 1990 to 2018. And they looked at everything related to the PCOS, reproductive and metabolic aspects on bone health. And they picked up all the controversies related to risk of fractures, bone mineral density, bone markers, and that uncertainty, can PCOS improve or deteriorate bone health? And what did they conclude? They looked at 921 studies published on planet Earth with more than 31,000 women in PCOS group and more than 1 lakh controls. And they observed simple things. The first thing they assumed and they got from the evidence base, from the published literature, was PCOS in women with BMI less than 21 is associated with reduced BMD in the spine and femur. It decreased bone formation and lower levels of circulating osteocalcin, which means the bone formation is less. So that is what was there. However, the bone parameters in PCOS, when we get adipose or when the BMI goes about 27, obviously gets into a neutral zone. So probably it may not be protective, but it is certainly neutral and does not deteriorate. So who are the women who need to be red flagged? In a premenopausal state are the women who have a BMI less than 27. They are likely to have a lesser BMD on spine and femur, lesser bone formation and osteocalcin. And if they are more than 27, it may be neutral and they may not have a necessarily direct link with excess fracture risks. So that is something there. However, we still need to do more prospective work to look at the existence of increased risk of fractures in women with PCOS in the post-menopausal state. And that has been well documented because that so-called estrogen deficiency then predominates and the androgen protection kind of weans off in the post-menopausal state. And therefore, we are definitely seeing an increased incidence in that cohort. So when we look at PCOS, we have to look at premenopausal and postmenopausal. We have to look at BMI below 27 and BMI above 27, and then contextualize it from that standpoint. And then decide who is the vulnerable woman who is needing attention on bone health and strengthening of bone health. And that is where the evidence base stands. As I said, there are a lot of controversial studies in either direction, but currently two things are very clear cut, that obesity overall has a protective role. Androgens and estrogens overall have a protective role on the bones, and deficiency of androgens or deficiency of estrogens definitely deteriorate bone health. These are some simple hormonal facts which are well documented and well demonstrated.
But Shashank, we have a lot of postmenopausal women who never knew whether they had PCOS, right? They were never diagnosed as PCOS in the past. So the question is, now we are diagnosing younger women today. Now, when we diagnose them in the postmenopausal phase, we find that yes, they have osteoporosis. But when we look at PCOS girls who are in the younger age group, we never normally ask for DEXA at that age because we believe that the peak bone mass is still 35 and then the woman starts losing bone. So in your opinion, as an endocrinologist, what do you think we should do with PCOS girls who come to us? Should we all actually do their bone densities earlier in life rather than waiting for them to reach menopause and then do their bone densities? What do you think we should advise our PCOS girls?
So in a lean PCOS, where the androgen excess is not preponderant, I would look at bone health more critically and may do a DEXA. But in an obese PCOS, with androgen excess, I may not do an DEXA. That's where I would look at it from that standpoint. So if you have a lean PCOS, we have family history of fractures, family history of osteoporosis, probably those are the situations where I would definitely, with a BMI below 27, I would definitely look at the bone health more critically and look at a DEXA screen there. Remember also below 40, I would definitely look at the Z-score. I'm sure Bhavin will highlight on that rather than looking at just simple T-scores. And that's what I would be focusing on. So in that milieu, probably I would not be screening a lot in the bone health standpoint.
So that would be your message to the gynecologist when they see young women, who are lean PCOS, whether they should be focusing on their bone health much more than we would otherwise.
Absolutely.
Right?
Absolutely.
That's, I think, important. I don't think Bhavin must be seeing too many PCOS girls coming to them at a younger age for bone density. Do you see them, Bhavin?
So nobody really tells us what the history is when they come for bone density. And it's irrelevant to the report because one of the only modalities, if we call it a radiology modality, where we don't look at the image, is the DEXA scan. And so you're just looking at the numbers and saying whether the person is osteoporotic, osteopenic, or not. And so as Shashank said, if the Z-score is less than minus or is higher than -2, then it's normal in everyone who's either premenopausal or below the age of 50. And it's only when the Z-score goes less than -2 that we start saying that, yes, there may be osteoporosis. But I don't get the history at that time to know why they've been sent.
Okay, so you're not aware whether they are PCOS, not PCOS,
No.
and you have no such information. Only probably by age you would understand that probably, someone has asked for it. But I think as gynecologist, Jyothi, don't you think that we normally ask for bone density in a girl who's got primary amenorrhea, or she's not menstruating, or she's had premature menopause? We would probably ask DEXA in those women, right?
Yeah. As Dr. Shashank has also brought out, it's mainly in this group of women or girls who we are concerned about their bone health for one of these reasons that you mentioned. And I would think that, we should be informing the radiologists on about why we have sent them. So filling of forms, like we keep teaching our residents, I think is very important, because they can only help us if we give them the history. They can give us much more information if we tell them why we are asking for a DEXA in such a young woman.
Correct. Absolutely. Shashank, since you're getting ready to go into another meeting, I have one question for you. There's this controversy about women joining, the Olympics and any other any games which are of national level or international level. And usually women, they do their testosterone levels for everyone, I presume, thinking that people are consuming testosterone injections or steroids or whatever. So these women who are hyperandrogenic, and if their serum testosterone is high, they're not allowed to participate in competitive games or athletics or races or whatever. So how do you handle that issue? How do we make sure that PCOS women are not kept aside? I think it's ethically wrong. But yes, they are hyperandrogenic. Probably they have better muscle mass and they will do better than the other women.
So this has, Guru Madam, become a very big sports controversy. When in 2018, the World International Athletics Federation had this big movement against a athlete which had androgen excess. And they have actually got testosterone cut points to understand whether, one will be eligible or not. Unfortunately, a lot of PCOS women will get ineligible if they have a high free testosterone. And that's kind of sad. There is a global petition happening on that. But currently, many of them will get out because they feel that there is an unfair androgen advantage they have. So that is why they currently get eliminated. And actually, there are some global criteria now on the testosterone cut points on the elimination of this. Even this was applied at the Japan Olympics. And now we know that if the testo levels are in the androgen excess range, there is an unfair advantage. So from a fair play standpoint, they feel that that may not be advantageous to them. And that's why they have been eliminated currently.
No,
and
but
that's not
levels, sorry, but those levels will never match the male testosterone levels.
That is true, ma'am. But unfortunately, what's happening is that the global bodies have not been able to give them justice. And this matter is still in global courts and in the various sports medicine expert bodies. And the verdict on that currently is negative. And therefore, this is a advocacy movement which we need to still generate in a bigger scale.
Exactly. I think that's something we need to really look at seriously. Tvisha, you must be knowing something about what's happening with these athletes who have PCOS and are not allowed to participate in the women's teams.
Correct. So like Sir mentioned, these cases have been going on. There's a couple of Indian athletes as well who had these high androgen, and even globally some. The main contention, is that I know you mentioned that the levels are not as high as the male athletes. However, the levels are higher than the female athletes. So the thing that they're fighting about is that it's not a level playing field, because they are getting an advantage compared to the other female athletes, and they are competing with other females. So, but the fight is that yes, they are not, they're females otherwise, and they are not high enough to be competing with the males. So that's when the medication coming in and all of that coming in. And so it is, I think cases have been going on for years almost, on the court of arbitration of sports. So I think it's been a confusing situation whole on whole. Luckily, not many cases in the elite world which have, come up like this. So that's luckily good. But having said that, yeah, definitely, studies have said that PCOS women, when we're looking at sarcopenia and muscle mass, there tends to be a higher muscle mass. So, yes, there tends to be. So it's not just that your testosterone levels are high. And it's not just that your testosterone levels are high. Your muscle mass, it has been found. So various, imaging modalities have shown the muscle mass to be high. And even you take something more functional, like their muscle strength capacity. So when their muscle strength capacities have been compared to controls, like, if you take PCOS women and controls, their muscle strength is also found to be high. So it's not just the blood levels that we are talking. Even functionally, they do tend to have higher strength levels. So, so it's not just that it's just a blood level, no, functionally also they are slightly better. And usually we backtrack that, okay, why are they functionally better? Because they have high, they probably have a little androgen excess. That's how they are. Although they have PCOS, they are not a medical case because they're still better off. So it's not just blood levels. So they do have a slight advantage. And that's where I think the situation is getting complicated even for the top level world-class endocrinologists to, figure out this matter, I think.
That's a good this thing for the PCOS Society of India to work on and, look at how we can have some advocacy for these girls and not prevent them from competing with other women, or probably having a separate group for them, or whatever we have to do. I think that's a challenge we need to take up. So I would go to Abhay at this point in time, and I want to ask Abhay whether he has seen any, sort of osteoporosis or in younger women. Do you come across such women who have very young, maybe 35, 40, and you have seen osteoporosis in them?
So shockingly, men and women, there's a steady flow of young men and young women with DEXA scores that are independently low, and they're very, very symptomatic people, but they have all their blood markers right. So if you had low vitamin D, your DEXA would still be low if it is a chronically low vitamin D. So that doesn't count. You have, all the blood markers right, but just the DEXA is low. And some of them who are athletic, they present with stress fractures and stress risers. A couple of my running colleagues have had sacroiliac stress risers, and the only thing you found was low DEXA scores. Now, being low IQ orthopedic surgeons, we don't really get into the depth of, where this is coming from. But one thing is for sure, that if you treat it, their symptoms go away. And I stick my head out because all my endocrine colleagues, they, point fingers and they say, you will definitely find a reason. And, you tap the reason, and I can see Dr. Shashank rolling up his sleeves. But I'm sure there's an answer to, this question. But the fact is that if you treat the osteoporosis, their symptoms go away. And their symptoms are, pains and inability to perform the way they were before. Invariably, they're young, fit athletes. And just going one step further, there are these, girls around delivery time who had really low bone. We've actually published 2 cases of multiple pelvic fractures around the delivery time, which is osteomalacia related. So they're 2 different things, but yes, the short answer is you see more and more of them. I think it's lifestyle related.
It's probably too much of computers and too much of TV and not. But you said you're seeing it in athletes also. Athletes
also. So I'm not sure. Shashank, are you listening? Do you have any quick answer to that?
Sorry, I missed this. What did you say?
Yeah, young athletic men and women with low bone density on the DEXA, with all their blood markers right. When I say all, I mean all orthopedic blood markers right.
So very rarely we get hypothalamic amenorrhea in athletes. And Duru ma'am, I'm sure you see them also. And, our gynecology colleagues see that in the hypothalamic amenorrheic athletes, you can, and their peak bone mass often gets not formed on time. And they can have a little frailer bone health. So that's the only situation where we need to look at the Z-score. And we occasionally do get.
He's talking about young men also having such problems.
2 very popular runners on Marine Drive. Everyone knows them. I should give their names out, but they've had completely normal bloods following over the last, the year before, and both have come to me with back pain, and actually it was coming out of a sacral stress fracture. And all they had was low bone density on the DEXA, significantly low, like -3 types. And they were all, under 40.
So maybe they are osteomalacic. and they might be having a lot of low Ds because, predominantly the vegetarian populace, poor muscle mass. We do see this. I also see this. And I think, do their androgens. They might have very low androgens also. Many of these men have very low androgens and, testosterone, SHBGs, and so on and so forth. So definitely they merit definitely attention. And we are seeing that. Often this is seen in smokers. It is often seen in leaner individuals. And definitely we do see these low BMDs. So I'm not denying that, Abhay. We do see them completely. And FACC probably is the only, as I said, your spine is a window to bone health.
Okay. So Dr. Jyothi, I mean, you see menopausal women as we say that menopausal women, if their estrogen is low, they have a problem, they have osteoporosis. There are many women who are actually, who have been probably PCOS earlier, but as they are getting towards menopause, the androgen levels start dropping and the estrogen levels also start dropping, and therefore they have these issues. But it seems obese women, as even Shashank was discussing, somehow have better bone densities. So could you explain something there with women who are obese?
Yeah, well, it's probably partially related to, the peripheral conversion. And so their estrogen levels are probably higher than the non-obese women because of the fat. And also there may be something related to vitamin D, the insulin resistance, all these things may be playing a role. And that is how maybe these women are not as osteoporotic, or even if they are, the fat seems to protect them from fractures. So even when they do fall, they don't seem to fracture as easily as lean women. So perhaps all these things are helping to keep them protected from fractures.
So Bhavin, when you do the DEXAs, are you normally only looking at the bone, or you're looking at the fat and you're looking at the muscle and you're looking at everything else whilst imaging?
No, it's typically only bone. We look at fat, etc., only if the patient has come for a specific whole body composition DEXA as well. So that's not routinely done unless it is asked for, and it's rarely asked for, except we're doing some studies with thalassemics and stuff like that where we do it routinely, but otherwise no. So then we only look at the bone. But yes, if the person comes for a whole body study, then you actually get an entire compositional analysis with the fat fractions, the muscle fractions, etc. I mentioned that in the report, but obviously what to do with that is something that would be in your domain.
But do you think you should recommend to actually gynecologists, where we are talking about, where they see women all the time, as to ask for anything specific when they're writing to you for a test of a bone density? Would you recommend that they also do the fat and the
I think so. I mean, now that I'm listening to all of this, and if this does make a difference to management, then yes. So the way it would be written is, please do a DEXA with a whole body study or with fat and muscle fractionation. So then we do it.
So if you have a, Tvisha, if you have a woman who's obese or who's lean, comparing the two, and you get a DEXA report from Bhavin which says that fat content is so much and the lean mass is so much, how would you interpret it in terms of how would you guide that patient in terms of what kind of therapy would you give them, lifestyle, for the osteoporosis they have?
First, on what the previous question, just to take that, we regularly actually ask for a body composition analysis. Sometimes we actually ask it more, we ask for a DEXA more for the body composition analysis rather than knowing the BMD, not just for our athletes, but for all this lifestyle kind of population that we tend to see, because people come for either weight loss or, we want to build muscle, that's their goal. So then DEXA currently tends to be the most, it checks all the boxes for, accuracy and ease of doing and those kind of things. So we do that one in our field for athletes as well as for the common lifestyle population. We do it as a fairly common modality. Now coming to the people who have, to answer your question on when it's low. So of course, one is the medical management, the hardcore medical management if they require, and then coming to the lifestyle management, which is typically exercise. So of course, they would see an endocrinologist and figure out if they require medical management for their BMD, osteoporosis or malacia. And then for this, going through their complete dietary as well as their physical activity history is what I will say. Now for BMD, there's always been, traditionally we had known that it's going to be high impact exercises, weight bearing impact exercises, which increases the bone density. To the extent that actually when I studied my sports medicine, there was a group which said that in schools, they actually make the girls jump for 10 times in between every class, like every 45 minutes, they would actually get the girls to jump for 10 times because they said that that's the time you're building on your, bone density, your bone. And so, they would get that. So that was the kind of the norm which was there in some of the, one of the US states that I was, talking to, that they actually came up with such guidelines. So it was always about high impact activity, weight bearing, high impact. However, most of the recent literature and a lot of the meta-analysis which have been done recently have said that it's a lot of resistance exercises also. It's not just the weight bearing. So we've had a lot of time, females who've been doing, because aerobics was obviously a massive culture, say about, 20, 30 years back. So the ladies who are now in their 60s, were doing aerobics, for all their life, and now they have low BMD. So they are like, how is this even possible? Because I've been doing aerobics all the time. So it's not just the weight bearing exercises, but it's a combination. It's weight bearing plus a lot of resistance exercises. The theory probably being that, the pull on when you do the resistance exercise, the pull on the bones is probably helping it build or something. So it's a combination of weight bearing, resistance exercise, and it's a combination of the two is what we would generally prescribe. When it comes to that for the BMD, for the bone, and when it comes to looking at the muscle and the fat, again, it's a combination of aerobic exercise, which could be your cycling, running, weight bearing or non-weight bearing like swimming. But in addition, always including strength and resistance exercises, which tend to get overlooked because the muscle, and especially in this category of females, whether it's PCOS or it's postmenopausal and all, with insulin resistance, coming in, muscle being the biggest insulin absorptive tissue, insulin sensitive tissue, the muscle works best when you do strength exercises, resistance exercises. Yes, walking is also a strength exercise in a way because you're going to be anti-gravity, for a few split seconds kind of a thing, and you're standing, so that's anti-gravity. But actually lifting up a weight and, going anti-gravity has been shown to have a much higher impact. So it's always going to be a combination of exercises, depending on whether you want bone, fat, muscle, the variation, the proportion would vary slightly here and there, but it's always a combination of exercises.
So I think in PCOS it's considered as a pro-inflammatory condition, and that's another reason why you have these different exercises needed to balance out the pro-inflammatory and the anti-inflammatory part of the entire treatment. So I think when we talk about these exercises, and Abhay, I wanted to ask you that as a spine surgeon, what recommendations you have, for your patients? Like, say again, if I'm coming back to the lean patients and the obese patients, what are your recommendations in women who have got a low bone density, as seen on DEXA? Or do you also ask for muscle and fat, full body composition, or do you just depend on the bone structure and then guide the patient?
So there are a few things that I wanted to just add to this because a very good discussion that happened. So the first is that though fat is protective to falls, and high fat is has had a positive correlation with low bone density, if you may, it's bone protective. it does not mean that fat people don't get osteoporosis. Fat is not bone protective. Fat is injury protective, like wearing a padded jersey. So you still want to get that fat off and add muscle and, become a healthier person. On the count of the DEXA scan, like Tvisha mentioned, we hang a hat on the DEXA scores because we are used to seeing numbers and we like to fall back on numbers. But the DEXA is a vastly overrated methodology of actually judging osteoporosis. And there are too many loopholes, and Bhavin is going to tell us what those are, but there are just too many. If you just take a DEXA from two different machines, you're going to have different scores. The ethnicity, the normal values of the DEXA, they all are so variable, and machines are variable. The way the DEXA is done is variable, AP, lateral. So the DEXA is a really small chunk in this entire, and if you see the FRAX criteria, the FRAX, the fracture risk assessment score, which is really what you should go by. There are 10 criterions and only one of them is a DEXA. So DEXA is really 1/10 of your diagnosis of osteoporosis. And it's just that it's the only test that gives you a number. And a lot of times you get a DEXA done to put it on the face of the patient. Look, you have weak bones and weak muscles, but we try to make, more of the sarcopenia because that's far more reversible than the osteoporosis. And we use this DEXA mainly to thrust on their face. As far as exercises are concerned, I think there's a simple algorithm that until you're 35, you can still build your bone mass. So at that time, you really need to plow in and do a lot of weight bearing as well as muscle building exercises. Weight bearing because bones are living tissues. If you challenge them, they will develop. If you don't challenge them, they will not. And muscle building because muscles supply bones. So like muscle is is where the bone where the bone is kept. So if your muscles are good, the blood supply to the bone is better, and obviously your bones are going to develop better. And hence, resistance training, and especially in Indian women, if you see across the board, the risk values are significantly lower than their other values. And one of the reasons being that, a lot of upper limb resistance activity is not done, traditionally. So 35 to 50 is a maintenance time when you don't lose or you don't gain for a woman. And at that time, it depending on what your peak bone mass is, you got to curtail the resistance. It has to be resistance as well as strengthening, but you got to curtail it based on what you got. And then beyond the menopausal time, you got to really go down and you get to therabands and maybe simple walks and cut out the running, jumping stuff. That would be my advice. Aside of that, vitamin D, calcium, proteins adequately in the diet. Proteins becomes a big loophole in the Indian diet, and you need 1 gram per kilogram body weight. And milk is overrated. You need 1.5 liters of milk a day if you really want to get your calcium supply. So there are a lot of these myths that go around, and we've got better experts to tell us about it. But I think you got to educate that with to the patient so that he or she's on the right side of their natural bone health.
Yeah. So I totally agree with you, and I think keeping the PCOS patient in mind. And have you seen anything different amongst PCOS, or you also don't know whether they have PCOS?
So, for us, it's a very clinical, like I the cost of being repetitive, low IQ orthopedic outlook. Is it a lean PCOS or a high bone, a fat PCOS? Sorry for using that word, but they're two different animals. A lean PCOS is a treated PCOS, I would say. And this person is in the same bracket or maybe at a higher risk of having poor bone mass and poor bone density. So if it's a girl who looks normal, visibly, and says I have PCOS and someone told me, I would just treat her in the normal category. And in fact, I would put a red flag on her because she's likely to have, because they are known to have low vitamin D in their growing years, and they would be more at high risk. While an more obese PCOS would be bone protected, and they typically across the board have good bone values, and they have other problems, and you got to get their muscle to fat ratio correct. And the muscle support of their trunks get better to improve their back or even their limb problems.
What would you think is a good muscle to fat ratio?
Oops, that's a tough one. But Tvisha, maybe I'll bounce it to Tvisha. Tvisha would know better.
Maybe Bhavin can.
No. Let's leave it for Tvisha to.
Okay. Tvisha.
If Abhay is low IQ as an orthopedic surgeon, we are also some low to middle IQ when it comes to these kind of things. So it's all good.
Question is that yes. So even the lean PCOS, we have to be wary of. We have to make sure that they have a good skeletal mass and good muscle mass, and even the obese ones, we have a problem because they are the ones who are actually not really, I agree that they do exercise, they try, a lot, but because of the extreme amount of insulin resistance they have, because of the PCOS, plus the obesity, it's a combined, it's double trouble for them. There is a lot of insulin resistance. And today, actually, most of the guidelines say that if you have an obese PCOS, you don't even need to do their insulin levels. You just take it for granted they are insulin resistant, period. And you treat them for their resistance. And frankly, in my clinical practice, I find that when I do give them metformin, that's an insulin sensitizer, they are able to lose weight much faster as compared to when they are not on insulin sensitizers. And because they keep constantly say, Doc, I'm exercising, I'm doing as much as my friend is doing it who's not PCOS. But we walk the same time, we walk at the same speed, but she's losing more weight than me. So, and when we give them the metformin, it really works wonders. And they are able to lose weight and they are able to get rid of all the fat. And hopefully, whilst exercising, they are building up on their bone and their muscle. So this is what I feel we need to work on. They've got hyperandrogenemia, they've got insulin resistance, they've got two major problems. So these are the two problems we need to tackle. And lifestyle change, of course, as Tvisha said, is very, very important. We need to do that. And coming to the, the FRAC score, which Bhavin, you were talking about. I think Abhay was talking about the FRAC score. So when we do the FRAC score, the only disadvantage is that you have to do a DEXA for the patient. There are 9 points which are clinical, but there's 1 point where you have to do the DEXA. And without that DEXA, you cannot complete your FRAC score. Is there any scoring system which we can do where you don't need a DEXA, but you can identify the patients who are at risk of having osteoporosis?
I would say 100% yes, but that's a purely judgmental thing out of your head. So a lady who's lean,
yes.
A lady who reports a weight loss, especially after menopause, a lady who's symptomatic, they talk of inertia of work, they talk of fatigue at work, a person who reports a history of fractures and typically some foot fracture or some metatarsal or some chota mota fracture which went unnoticed, but that history, that record is there. They talk of their family members saying that they're now slouching. They talk of sometimes height reduction, and they know that by the clothes they wear. Either the clothes are turning loose at the sleeves, or therefore they know that the person inside is losing height. And a strong family history of of osteoporosis, which typically is well known, like it's a mother to daughter kind of a passage. So I would typically go by this to call them a high risk. And then even if their DEXA is a minus 1.2, I'm quite aggressive to treat them. And these are, in fact, some of the markers that will tell me that they're improving. My mom, for example, has all this. She's asymptomatic, but all the other things are there. So I've just put her on the maximum available, dosage of anti-osteoporotics.
Yeah. So I find that a lot of orthopedic surgeons, I'm not talking spine surgeons, orthopedic surgeons, who have treated women with fractures, have never told them that you need to get your DEXA done to make sure that you don't get another fracture. How much preventive therapy is there amongst the orthopedic population?
Which is why I called me a low IQ orthopedic surgeon, because across the board, orthopedic surgeons are bullheaded. Sorry for saying that, I'm one myself. We just look at the fracture, we fix it, and that's that. And just think about it, that if you had a tuberculosis of the spine with a deficit and I operated that person and didn't give him anti-TB drugs, what have I done? So that's exactly what a fracture is all about. And unless it's a low, high intensity, a road traffic accident in a young male, or, the sports injury, those are different. But anyone who belongs to the low intensity fracture, any hip fracture, any spinal fracture in an older person has to be given a backup treatment of osteoporosis. And that's something that we're trying to light up in this whole community so there's a huge wave in our, in the orthopedic society of just open your eyes to osteoporosis and treat it. Otherwise, you're going to have failures. Fortunately, those who miss out, it comes back at them because some failure of implant happens, some adjacent level fracture happens, and then you can't run away. So the cleverer ones are preemptive and the others are just waiting for a repercussion of their loss.
But
Duru, sorry to interrupt, but
Yeah,
it just reminds me, I'm just going to add to what Abhay said. 98, 99 is when we put up that first DEXA, and nobody knew what even the definition or of the word osteoporosis. And I went to an orthopedic surgeon, a very senior one, and I said, we've started this and we can measure. And he's telling me in Gujarati, you know, I'm a carpenter chair. You know, we're carpenters. We don't understand all this. We can fix stuff. You're telling me people have osteoporosis. I'll give calcium to everybody. Why do we need to do DEXA, you tell me? And that was the end of the conversation.
Yeah, that's true. But coming to definitions, actually, Bhavin, from your point of view, we discussed it with Shashank.
Sure.
What's the difference between the bone strength and the bone density? Is there any difference?
So what we measure is bone density. And obviously bone strength, and Abhay has been stressing that it depends on a lot of other factors. It's also about how your trabeculae are placed, what is the cortical thickness. It's not just based upon the numerical value that you have. And even if your bone strength is not very high, you may still get a normal bone density reading and vice versa. So the two things don't necessarily go hand in hand, though as a rule, yes, you have low bone density, you're likely to have low bone strength as well. But there's much more to strength than just the measurement of density.
So the classic example is people who suffer fractures after long-term alendronate treatment. So they get very strong per se, their density, because their mass for volume increases, but it's brittle bone. It's not anatomic bone. It's not bone quality, it's bone quantity. And their bones start snapping like chalks. And in fact, right now, again, we're missing Shashank here, but there's a wave in the International Osteoporosis Federation to actually go away from alendronates, which till a few years ago was our, key treatment for osteoporosis, simply because it increased the bone density, but does not improve the bone strength.
You see tensile fractures all the time.
Yeah.
So what is the maximum amount of time duration you would give anyone the alendronates?
The US FDA is approved 4 years. So that's what we go by. And after that, they have no statement on it. So until the denosumab came along, we were forced to give them a treatment holiday and then restart. And then people have had alendronate for years on end because of lack of any other medication available.
Yeah. So each one, of course, has their own issues. Even denosumab, there was an issue about it causing some problems, wasn't there?
It has the best safety profile as far as side effects are concerned. The problem is that it's still not a bone former, it's a bone harnesser. It still stops bone loss, and it doesn't have a net effect, anything much greater than alendronate, though they're trying hard to prove it, the pharmas. But in reality, it's still not been proven. And the good thing is that it's 10 years consecutively you can give denosumab. That's the only good thing.
Yeah, but it's how would you compare it to parathormone?
So parathormone is clearly top bracket. I'm not sure if the pharma has been feeding this to us, but there is huge amount of literature suggesting that parathormone actually builds optimum new bone, and that's a game changer in the treatment of osteoporosis. And even within my short career, there's been a sea change in the way we see patients. And on a clinical perspective, it is literally a game changer. There are patients in whom everything is crumbling, and with I'm actually in the process of publishing some cases that were out and out surgical, and they were just harnessed or cleared by 1 year therapy of teriparatide. The big problem with teriparatide, that very limited indications, a lot of issues as far as side effects are concerned, and duration. You can't give it for longer than the FDA approves of it as a one-time 30-month therapy. And it's difficult to do that because no one wants to take injections every day for 30 months.
It's a daily injection.
Daily injections, yeah.
People get completely put off taking it, and at least 18 months you have to give.
But hand on my heart, my mom is taking. I've made sure my mom takes it. So I'm very, very much sold out to this drug.
Absolutely. So Jyothi, when you come and treat, we have guidelines for menopausal hormone therapy. You know that many women are, not willing to take it, number one. Second thing is, and even if I have prescribed it to a patient, the next person, maybe the endo or maybe the ortho will tell her, no, don't take it. It's not good for you. So what do you have to say?
Yeah, see, for women, actually, menopausal hormone therapy, if they are in the age group and the time since menopause and all, it is probably one of the best things to give, because it really there's enough data to say that it not just increases bone density, but it reduces the risks of fractures also. And this is for both vertebral and non-vertebral fractures. And so I would say that in women who are perimenopausal or less than 60 years of age or within 10 years of menopause, I think that should be the first line of therapy. And just while talking about denosumab, the other thing with denosumab is that because of the anti-resorptive action, now several societies have sort of said that after completing the course of denosumab, you should give some agent like zoledronic acid or alendronate. So these things have to be kept in mind, that when the drug comes newly, everyone is gung-ho about it, but over the years, you come to know that, okay, like alendronate, we were so happy about it, and people thought that rather than giving hormone therapy, which causes breast cancer, you should give alendronate, since all these, till the reports of the fractures came. So as far as hormone therapy is concerned, if the woman is younger than 60 and within 10 years of menopause, yes, I would say it should be the first line for such a woman.
What do you do for the guys?
I don't do anything for the guys. So we'll let Abhay or Tvisha take that, since Shashank isn't here.
No, I thought of it because I had a very couple, I won't say which community, was with me, and I was talking to the lady how the hormone therapy will help her. She was about 54, 55. And I gave her all the advantages and everything about hormone therapy, and talking to her about her bones, etc. She was pretty convinced and she was happy to take it. Then the guy tells me, can I take it too?
Tell him you'll become Michael Jackson. You're sure you're welcome to take it.
So that's why I asked you that. So Tvisha, what would you do about, situation wherein you have a patient with, osteoporosis, and you're also assessing their muscle strength. So bone strength and muscle strength. We talked about strength. How do you assess it clinically?
There are various ways to assess bone strength. Simple things starting clinically, but that's obviously something very crude. It can be done by, so when we are talking muscle strength and there's muscle function. So, all the definitions always, of sarcopenia, they always say that there's muscle mass, there's muscle strength, and there's muscle function. The latest literature always says that, assessing the function is the best way to go about it. But still, we still do strength assessments. So if it's a very frail patient, simple tests like, the timed up and go, which is the TUG, has always been the, globally, that's the common test which is used, where somebody gets up from a chair, walks a particular distance, comes back, or just sit to stand from the chair. So these are the popular elderly tests, which are just to test their functional capacity as well as strength, with the simple sit to stand. Then we go on, we have machines. The hand grip strength has been the one which has been used commonly. How, people, the layman often obviously sometimes finds it very amusing that, how are you checking my whole body strength by just the hand grip? So it's been, proven in studies that whether you check, some other part of the body or just your hand grip, it's been correlated. So check their grip strength. There are fair cutoff values which are there, 20, 30 kgs, and that gives a fair assessment of the strength. But if we really want to go into detail of individual muscles, there is a dynamometer. So dynamometer is basically an instrument wherein you put some pressure, and it gives out the values of how much pressure has been put and how much the person is able to push against it. So those dynamometers can be used for arm strength, for quadricep strength, hamstring strength, pretty much most major muscles of the body. Those dynamometers can be used. Going a step further, there is something called an isokinetic dynamometer, which is a fairly complex machine. Typically used predominantly for athletes, but in our hospital we also use it for other people, and in rehab centers they use it for others as well. Again, the logic being you attach a particular resistance to the person, and it's about the person has to push against it, and you can see the numbers. So these are the complex machines. The other end is the simple asking the frail person, just asking them to stand up and see if they have enough strength. And in between, we have what we call the RM test, which is a repetition maximum, wherein you put a person on the traditional gym equipment, okay, and you keep checking as to how much weight they can push till they can push just like they should be able to push just one time. So, typically in exercises, we do repetitions. So it's called a 1 RM test. So if normally people do 12 or 10 or 12 reps for an exercise. So suppose you can push 10 kilos for 10 reps, but you keep increasing the weight so that you can push only one repetition. So there are certain guidelines for certain populations that how much they should be able to push for each not for each muscle but for each movement. These guidelines are not for muscles, so we just take the quadriceps, it's for knee extension or something like that. So this is an in-between type of when somebody doesn't have a very fancy equipment of a dynamometer, you can do this kind of test. And so I think that is the strength paradigm that we have. Of course, then we have things like just calf muscle girth, calf girth, thigh girth, all of these, but they are not measuring your strength, but they have been found to correlate fairly well with strength. So in a very, very crude community setup, say we are going out to do like a field, in the field setup, if you're not taking much instrumentation, something like just a calf girth could just give a little indication that, yes, what is going to be this person's strength. But otherwise, these are the various ways we could assess the strength.
I think that is very, very comprehensive way of assessing strength. So since you talked about, a very rough way of assessing, I wanted to ask Bhavin, how would you compare the ultrasound bone density, densitometry to your DEXA? I know it's way apart, but suppose I'm in the rural and I don't have access to bone density. If I do ultrasound guided, they put that foot in and get it, how reliable would it be?
So those have gone, no? They're no longer around because they were, so historically what happened is somewhere in the early 2000s, the ultrasound bone densitometers came into the market. They are sensitive, but they are highly non-specific. So they have a large number of both false positives and negatives. But the idea was exactly this. You do a camp, you go to a rural area, you put your foot inside, you screen 1,000 patients over a weekend, and then you identify some. Chances are if they are abnormal, they are osteoporotic, and then the pharma companies would do the camps and dish out the Rocaltrol and calcitriol. I know I'm taking brand names, but whatever it is, they used to do all that. The challenge is that over a period of time, all the data that came out, all the studies said that they're just not good enough. And then eventually when the medical support from the endocrinologists, rheumatologists went down, the machines just disappeared. So to the best of my knowledge, I don't even think they're in use anymore. Maybe on and off if somebody still kept a machine, but the machines were all owned by the pharma companies. No radiologists actually ever bought them except one, and then they got rid of them in 6 months and things like that. So right now, the only two methods that are used to measure bone density are DEXA and quantitative CT. Quantitative CT is equally good. Technically, there are no issues, but it's just not worth putting a patient in a CT scanner, wasting both the time and energy of the CT scanner, as well as, doing something that is very rarely done. Because as Abhay said, you can't compare different modalities. So if you decide to do QCT in somebody, you have to continue doing QCT in that patient all the time. In fact, with DEXA, you have to repeat the DEXA with the same institute or the same imaging center. You can't even go to somebody else who has the same machine because their QC may be different as well. So effectively, you're just left with DEXA now. I mean, there's really nothing else available.
Is there much more
sorry.
with QC? Sorry. Is there much more radiation with QCT compared to DEXA?
A little bit more, but radiation per se is so overhyped that it's not really an issue.
It's not really a problem. Okay, fine. Yes, sorry, Abhay. Go ahead.
So QCT is actually far more accurate. It actually gives you the bone density. But the values that we see are standard deviations from the normal. They are not actual values. It's not like a hemoglobin is 11. It's a standard deviation from the normal. And because we don't have the normal values for Indians for the QCT, that's where it flops. And that's been the problem across the world. And DEXA we have, and that's again our, our hype with numbers. We just want that number. And USG is such a sad way of, judging bone density. All you need to ask is those 5 questions that we mentioned some time ago. And in any rural camp, you'll know who needs osteoporosis treatment, but you don't want to do that. You want to get a number. And that's how you put your foot into that machine and, dish out the Rocaltrol or whatever.
No, but it's a fact, in the villages, they don't have any of these, even in the district hospitals, they don't have DEXA machines. How are you going to, sort of come to a diagnosis that, yes, this one has osteoporosis?
No, that's what I said. Those 5 questions, have you lost mass? Have you lost weight? Blah, blah, blah. And even a plain X-ray of a PBH X-ray, pelvis, both hips, the ward strangle is quite, nowadays, most places have digital X-ray. So there's no, that variation goes away. And a ward strangle assessment is quite often reliable.
It is. It's absolutely.
Talking about villages, Abhay.
X-rays.
They have problems for everything, no? I mean, where this is just one small problem. I mean, you can't even measure, take care of other problems in villages. So
that is very true. Very true. It's unfortunate, but it's a fact. And we faced that when we did a project at Latur. We couldn't get that exercise done. We couldn't do vitamin D. We had to send the blood out, and we couldn't do a mammography was possible, but in a private institution, not in the district hospital. So it's a big challenge in the rural area where, nobody wants to work. Nobody wants to put that effort to get it done, unfortunately. Of course, we also know with PCOS patients, there's a lot of vitamin D deficiency known. We also know that non-PCO patients also have a lot of vitamin D deficiency. So in short, Abhay, what would you say about vitamin D for osteoporosis?
So
everyone do keep doing the test, keep just giving it. How does one monitor the thing?
So actually the statement that makes sense is that why is vitamin D deficiency an epidemic in Bombay? Because it is an epidemic. You, me, all of us are vitamin D deficient. But curiously, we did a study on this, and we had ultraviolet meters kept at Cross Maidan and at all the open spaces, and we realized that even when you're sitting under the sun, because of the smog in an urban dwelling like Bombay, there's filtration of the UV radiation. So even if you're out there in the sun, you don't get your natural UV the UV rays that actually convert or activate vitamin D from your subcutaneous tissues. Aside from the fact that we don't go out in the sun as often, and aside from the fact that you don't do adequate exposure, it's a mid-noon exposure that's needed. Contrary to popular belief, subere ke sun mein jao, that's wrong. You got to be there in the vertical sunlight because that's where maximum UV light percolates. Yes. So in short, everyone is vitamin D deficient, and all of us should be taking vitamin D. So the way most of us would take 60,000 units a month as a regular dose. And once a year, you check when you do your lipids and your, other stuff, you check your vitamin D. If you are low, you want to treat it. And if not, then Bhavin is furiously challenging whatever. Go for it, Bhavin.
I wish Shashank was here. I think one of the biggest challenges, and I know Shashank talks about this, is that the reason we are all vitamin D deficient is because we don't have Indian values. And so everybody tests low, because we're using values that are not really meant for our population. And the point is, if you're anyway going to be deficient, so if you see the current US Task Force Services criteria, then they keep doing this. They've said, what is the point measuring your vitamin D unless you're clinically sick? If everybody is supposed to be deficient, then you just give what you said, 60,000 international units every month, and you're done. Why even bother to measure the vitamin D in any case, right? B12 is different, but D that's the challenge. So I think this is really where the endocrinologist would have helped, because it's very controversial. And I think giving the advice that, yes, take the units is fine, but measuring, saying that everyone's deficient, I think we have a lot more ground to cover there over the next couple of decades before we do this. But yeah, at least we know that.
Maybe you're right, Bhavin. Just that when the vitamin D is below 10, it doesn't get absorbed also. So very often you need to give shots. So at least once a year to get a sense of where you stand. Tvisha, what do you feel? Do you get your patients to check their vitamin levels?
Yeah, even the athletes who are out there in the sun for 6 hours, they turn out deficient. So,
No, Bhavin is questioning the definition of the word deficient because
yes. So, but that's unfortunately the guideline is that in athletes you even want to keep that, you don't want to be in the sufficient range. You want to be a slightly higher than that. Unfortunately in the sense, like it's been very confusing. I was myself going to pose this question because so we have to put people on a pretty much round the clock supplement for vitamin D because our athletes as well, because that's what it is. Talking to on the question of what Dr. Bhavin said about symptomatic, if they are clinically symptomatic. So athletes obviously keep having aches and pains, niggles here and there. And I don't know if it's the placebo, but now they also know that it's the vitamin D that's going to help them. So funny enough, those things also go away. So it's like we're really confused, honestly speaking, with this vitamin D business.
But in clinical practice, we see too many people who actually respond or who have vitamin D deficiency when they come with aches and pains and they respond to it. And just dating it back, now they know that vitamin D is linked to the T cell immunity for tuberculosis. And that's the reason why sanatoria treatment used to work in the past without any AKT, without any ATT available. And now they're saying even COVID is the immunity against COVID is vitamin D. So my counter question would be, why not just why not just take it, forget about the normal values and just make sure
that's precisely what I was saying. We take it. That's perfect because anyway, you don't lose anything. You're not going to get hypervitaminosis with 60,000 IU per month. But why measure and why define is where I was coming.
Only the symptomatic population, I'd say, measure.
That's different. Hypervitaminosis is also not good, right? They've had people in the ICUs with hypervitaminosis.
Hypercalcemia.
That's true. I've seen patients being given a shot every single day for 10 days and they come with values of 150 international units of vitamin D. You have to measure it, there's no question. But when you talk about Indian standard, there are so many hormones we do, right? We are using all the kits, everything which are manufactured abroad. And all those values are based on what are the levels seen in the numbers or the patients whom they are, doing their trials on. And frankly, we are, according to me, even with insulin, we've done a study with patients, normal patients, and we find that the insulin levels are, very different from what the kit says. The kit says 25 is the upper limit of a fasting insulin. Normally, we are told not to even measure insulin because it has so many variations, you should not measure. But when you're doing an academic study, you're doing a trial, you're going to measure the thing. But you find Indian patients have a higher potential of having, higher insulin levels. They fall into a category which is, these are about 200 normal individuals we have evaluated, and we find that their levels are much higher than what you find. They fall in the last quartile for fasting. So we do feel ethnicity plays a role, and therefore the levels of vitamin D need to be done in our population. What I have found is in our patients who wear the burqa, the levels are as low as 2 and 3. As low as 2 and 3. The people who are exposed to the sun, at least we get levels of 14, 15, 20. But definitely somewhere the sun is getting into them. But in all this heat and etc., in the humid weather, nobody wants to walk out at 12 noon for that vitamin D. You rather take the vitamin D, it's just much better. I think that's what helps. Jyothi, any suggestions?
No, I was just saying that I was just thinking that since many of us are doing vitamin D so frequently for all our patients, we should just try and get that data together. We'll at least get what the urban Indians' vitamin D normative values are. We might not, maybe we are not going into the community and doing it, but if we sort of collect all our data, even 10 of us who are on this panel, 6 of us who are on this panel, we'll probably have at least 1,000 women whose, values we'll know. And, we could take it from there, because getting, that's the same thing with osteoporosis. DEXA, do our women fracture at the same T-scores as Caucasian women. Now, we don't know that. I mean, I know that I myself have a T-score of, -3. My mother has had a T-score of -4.5 and -5 for 15 years. Touch wood, she might have had vertebral compression fractures because she's, lost weight, height, but otherwise nothing else. So what exactly should we be treating all these people? Like, should we all be taking, injections of teriparatide or zoledronic acid, or should we take denosumab? Really, everything is based on Western data.
But Duru, we did those studies, no? We did in Wadia maternity in the early 2000s. We studied both the hologic and the lunar and the women and their fracture rates and everything. And we found that hologic deviates a lot by almost 30% because whereas the lunar machines are almost similar, the Caucasian data and the Indian data. And so effectively, there is not much difference, and we behave pretty much the same way as the Caucasian women do, because then Amrish Mittal did the same study in SGPGI, the National Institute of Nutrition did the same study. So while we don't use normative Indian data, we do know that on the lunar machines, and then, you just have to kind of be a little less aggressive with the hologic data. We're pretty much the same. So there isn't much to do in terms of using. So vitamin D is a different animal, and osteoporosis measurement by DEXA is different. I think we're pretty much okay using Caucasian data.
Yeah. So what I'm saying is that it may be the same for vitamin D. We just don't know. Like because we haven't sort of got all the data together, perhaps.
You can't have 80% of the population vitamin D deficient. It's not possible. There is something wrong there. It is. And the problem is, even if we take all our data and put it together, how do we know what is normal to begin with?
How do we say have to divide the guys into people who have taken the supplement now, because now it's literally become a
correct. That's another problem.
Everybody's just taken, we have certain packages for our athletes for fitness testing, and I have athletes telling me that how come you've not included vitamin D in this? That's the standard. I was like, listen, I know what's correct. I know what should be a package to check,
Yeah.
But that's the most standard test that has to be done. Without that, so it's not possible only that you can know my fitness.
Nowadays, they may not even do a thyroid, but they do the vitamin D in the packages.
At CMC Vellore, the orthopedic surgeon, I worked in Chennai for a very long time. So the orthopedic surgeon there, he said that they had done a massive study at CMC Vellore and they found the same thing. So back in Tamil Nadu, where, the sun is supposed to be pretty harsh as well. They said that they did this kind of thing for vitamin D and they found that as well. So
they've done it even on, agricultural workers and also women who are, their saris are up high, their arms are exposed. So their skin is exposed to the sun and still their vitamin D levels are low. That's a Chennai study again.
I have a question. We're talking about athletes and motivated people and physical activity. But I'm assuming that in your PCS, like it happens with the general population, that about 90% of the population worldwide and in India is physically inactive. So while we are talking about all these, because we seem to be physically active, how do you motivate the other 90% to do even a little bit? I mean, anything helps, right? Even 30 minutes of walking a day increases your lifespan by 3 years. How do you do that? I mean, this is for Tvisha and Abhay, and forget about the motivated people. They are anyway going to work out and do everything else. What do you do with the others, the 90% that doesn't want to do anything?
I use the MRI. I send them to you, get an MRI, show them their back is full of rubbish and tell them if they don't work out, they're going to need a surgery. And that's a threat enough for them to get to exercises.
It works, huh?
It works because it's a threat of the knife, right? Or you get a a good-looking doctor like Tvisha to refer to, and then I think that's motivation enough.
Otherwise, you give them a heart attack. Cardiac rehab is a big stinger for them. So once they get a heart attack, unfortunately, then a lot of people wake up.
Yeah, but the general population, let's say if people who are in their 50s, how do you, and let's even look at your PCOS population, how many of them actually, if they don't get an MRI done because they don't have a back pain and they don't get a heart attack, how do you get them to do anything?
So it's like behavior change. We all know the benefits of it. Literally everybody knows the benefits, but it's about that behavior change. It's a lot of psychology. So
there's a lot of counseling to be done, and honestly, we treat each patient individually to see what really works for that patient. And as I told you, sometimes they're just frustrated because of their insulin resistance, which may be very high. They're just not losing weight. So you put them on metformin, they start doing some activity, and I always tell them, you do what you like to do. You don't have to go to a gym. You don't have to go to a trainer. You don't have to go for a walk. You like Bollywood dancing, do Bollywood dancing. You want to do Zumba, you do Zumba. You want to do Kathak, you do Kathak. Whatever you enjoy, go play squash, go play tennis. Go. Half of the women don't play any sport, number one. So the question is, you have to give them some, you have to spend a lot of time with them. And honestly, I'm telling you, we've been able to make quite a bit of dent in these women by motivating them in terms of making them do some physical activity which they enjoy, number one. Second thing is that most of them say, oh, I want to go for a walk, but I get up in the morning, then I don't feel like going. I say, let me talk to your friends who are motivated. Make the motivated friend go to her house and be there ready for her to take her out. So, various ways we can work towards it. And it has worked in a large number of women, and who have, once they see the weight reduction, the frustration goes. I think many of them are really frustrated because they've gone to a stage when they say, oh, 30 kilos I have to reduce. How do I do it? I can't. It's that negative mode they get into. So I think maybe counseling helps them, send them to a counselor, or you counsel them. But I think it needs a lot of effort, yes, to go into. It's not very easy. What do you say, Jyothi?
And I think set small targets, don't tell them 30 kilos. Tell them, okay, your first target is 5 kilos. So if they need to lose 30, I mean, if it's somebody who needs to lose 5, then you say 2. And, probably see them, if you have the time, either somebody else sees them or you see them fortnightly rather than seeing them once in 6 months, then it's showing them that, well, they have done something right and they've lost this 500 grams. So if they continue like that, they will lose a little more. And initially, people who are very overweight, of course, as we all know, they lose weight initially, part of it is water, part of it is muscle, not really fat, and then they plateau, and then that is when the frustration sets in. So it's at that stage, I think, that we need to counsel them a lot. And something which we can probably tell a lot of them is that when you're on the phone, walk. So because a lot of them are on their phones for a major part of the day. So while they're talking on the phone, if they just walk up and down in their house or wherever they are answering the phone, they at least get in a little bit of physical activity rather than just sitting and talking on the phone.
That's true. I think in this whole discussion, we have neglected a little bit of sarcopenia. I just want to wind up with a little bit on how sarcopenia affects your health and what could it do to you. So Abhay, can you start this?
Yeah, I feel for me, sarcopenia is the key. And people don't even know about it. So, an average person a lady after menopause loses up to 7% of her muscle mass every year, and a male at 50 would maybe 2 to 3% every year just by doing nothing. So you have to run harder to stay in the same place, basically. And if you put that out there, because again, this is about counseling and telling people that this, startling fact that I mentioned. And if you're able to, and then the other big statement that always works.
They just feel that they also have this notion that, oh, because I have joint pain, it's only because of my calcium and vitamin D. They totally disregard the muscle. So it's a lot of showing them the results by actually getting them to do the exercise that makes them feel better. And yeah, I think that's from the sarcopenia point of view. And just to add on, so Dr. Bhavin, just 1 second. You know, when Dr. Bhavin was asking about how do we get people to exercise, one thing again that I've noticed is that in the obese population, all the elderly population, because they have certain aches and pains, especially in the knee or the hip joint or the foot joint, very often their recommendation is, you know, just to walk. But they do not understand what to do because the walking produces pain. Then the pain puts them off for 3 days when they cannot do anything, even their daily activities. And so they get into this loop. And so that's where a good exercise prescription, which is, you know, if they have pain with the walking, suggest them an alternative activity. It's not that you have to, you know, have some fancy equipment, you know, even activity which can be done at home. So I think a good exercise prescription, which takes into account what are the person's other limitations, physical musculoskeletal limitations, in addition to the metabolic problems, is very important. So it has to be a balance of two, because otherwise, you know, that probably very often people write down, go walk for an hour, but the person never walked. You ask them to walk for 1 hour, that and that puts them off, because they suddenly start doing it for a week, and then they're so fatigued. They are like, no, exercise is not for me. So small steps, like Dr. Jyothi ma'am said, that, you know, it has to be small targets, but also you have to start with small steps. So this exercise prescription, I think, has to be done very intelligently and precisely by an expert to, you know, make that better. So Dr. Bhavin, sir.
No, but I think the one issue that we sometimes, and this comes from the whole sarcopenia thing as well, is that we need to de-link weight loss from cardiorespiratory fitness. The two things are not necessarily the same. You don't always lose weight if you're fit, and vice versa. You could lose weight and still be unhealthy. And I think by focusing on the fact that you need to be active so you will lose weight, actually creates a lot of angst and trouble, because you could be really fit. I mean, I have reached a plateau where now whatever I do in life, I will not lose the weight that I have, because it just, the body eventually finds that particular balance, and that's it. But that doesn't mean I'm going to stop my running and, you know, going to the gym, etc. But a lot of people get demotivated once they either put on a little bit, and they will put on. If you need to, you know, get your muscles to a certain level, you will not lose weight. I mean, you have to put on that weight to maintain where you are. So that needs to be de-linked. I think focusing on weight loss, it's great if you're running. I mean, if you're in a center that promotes weight loss, or you want to bring in patients, because that's how you get them in. But medically, cardiorespiratory fitness or any kind of fitness needs to be de-linked from the whole concept of weight loss. If you do that, you probably get more people to be physically active, which is more important than just losing weight. So just my 2 bits on that.
Yeah, so essentially de-link exercise from weight loss.
Yes.
That exercise. So if somebody sees a thin person in the gym, they are like, why are you in the gym?
Exactly.
Yes.
About exercising and weight loss. That exercise is not meant just for weight loss.
Exactly. Exactly. So you want to close the session, Jyothi, with your remarks on sarcopenia?
Yeah, so pretty much the same thing that as everyone has said, and that muscle strength is important. And most of the time when people are walking or running, they are actually losing muscle mass. So when they lose weight like that, they lose water and they lose muscle mass, and they may not lose fat. And what we want them to lose is the fat mass. And when they do resistance training, the weight does go up in the beginning because the muscle is heavier than fat. So they need to understand that and try in terms of increasing their muscle strength. And particularly as they grow older, it's important that they maintain that muscle strength, because only then they can maintain their bone health also.
So thank you very much, everyone. I think we have had a very, very nice discussion with all the experts over here. And I really thank the faculties of Dr. Jyothi, Abhay. Sorry, Altamash is not here, but Shashank, who had to leave us and do a prior commitment, and Bhavin and Tvisha. Truly happy for you all being there and sharing all your experiences and expertise. I also thank Omnicurus, Mr. Shobit, Mrs. Lena, and Mr. Faraz, who have been very helpful and They give us a great platform to discuss all these issues. Our corporate sponsor has been Torrent Pharma, especially Mr. Maruti and team. The PCOS Society team, mainly Dr. Zoish, Mrs. Rochelle, Aarti, and Sejal, and all our delegates for being with us and sharing this last 1.5 hours with us. We truly appreciate it. Thank you so much, and good night to all of you.
Good night.
Good night. Thank you, everyone.
Thank you.
Thank you.
So thank you.